Hey everyone! Welcome back to Explain Wise 91, your one-stop channel for mastering the NCLEX the smart way. In today's video, we're diving deep into OB/maternity drugs you must know for the NCLEX. These are the medications that show up again and again on real exams. We'll break them down the easy way, with memory tricks, rationales, and clinical tips you can actually remember. So grab your notebook, hit that like button, and let's make OB pharmacology simple and unforgettable. Question 1. A client at 39 weeks gestation has a diagnosis of preeclampsia with severe features. The provider prescribes magnesium sulfate 4 for seizure prophylaxis. Which nursing action is the highest priority after the infusion is started? A. Monitor deep tendon reflexes, DTRs. B. Check hourly urinary output. C. Assess respiratory rate every 15 minutes. D. Monitor fetal heart rate continuously. Correct, C. Assess respiratory rate every 15 minutes. Rationale: magnesium sulfate depresses the central nervous system and can cause respiratory depression. Respiratory rate less than 12 per minute is an early sign of toxicity. While DTRs and urine output are important, magnesium is renally excreted and loss of DTRs indicates toxicity. Immediate threat to life is respiratory depression. Continuous fetal monitoring is indicated but not the highest priority for maternal safety. Strategy: when a drug can cause life-threatening respiratory depression, pick actions that directly monitor that risk first. Question 2. A postpartum client is prescribed methylergonavine, Methergine, for uterine atony. Which finding would be a contraindication to giving this medication? A. Blood pressure 150/98 mmHg. B. Temperature 37.8 degrees Celsius 100 degrees Fahrenheit. C. Pulse 92 beats/min. D. Hemoglobin 9.5 g/dl. Correct, A. Blood pressure 150/98 mmHg. Rationale: methylergonavine is a potent vasoconstrictor and is contraindicated in hypertension due to risk of severe hypertension and stroke. Fever, mild tachycardia, or anemia are not absolute contraindications for this uterotonic. Strategy: remember mechanism, vasoconstriction avoid in hypertension/vascular disease. Question 3. Select all that apply. A client with a history of thromboembolism is receiving combined oral contraceptives postpartum. Which signs/symptoms should the nurse teach her to report immediately? A. Sudden unilateral leg swelling. B. New onset, severe headache. C. Nausea and mild abdominal bloating. D. Shortness of breath and pleuritic chest pain. E. Slight spotting between periods. Correct, A, B, D. Rationale: combined estrogen-containing contraceptives increase risk of thromboembolism and ischemic stroke. Sudden unilateral leg swelling indicates DVT. Severe headache can indicate cerebrovascular event, and pleuritic chest pain/shortness of breath suggests pulmonary embolism. Nausea/abdominal bloating and light spotting are common minor side effects and not emergencies. Strategy: for SADA, select only items that align with the drug's most serious adverse event, here, thrombosis/stroke. Question 4. A woman in labor receives intravenous oxytocin to augment contractions. 30 minutes later the fetal heart tracing shows late decelerations with decreased baseline variability. What should the nurse do first? A. Stop the oxytocin infusion. B. Administer a bolus of lactated Ringer solution. C. Reposition the mother to left lateral. D. Give oxygen by non-rebreather mask. Correct, A. Stop the oxytocin infusion. Rationale: late decelerations reflect uteroplacental insufficiency often caused by hyperstimulation from oxytocin. Stopping the uterotonic immediately addresses the cause. Other measures, reposition, for bolus, oxygen, are important and often done quickly, but removing the precipitating agent is priority. Strategy: when a medication is the likely cause of fetal compromise, stop it first. Question 5. A woman taking magnesium sulfate has a serum magnesium level drawn. Which range correlates with therapeutic levels for seizure prophylaxis and preeclampsia? A. 0.7 to 1.1 milliequivalent/L. B. 1.5 to 2.0 milliequivalent/L. C. 4.8 to 8.4 milliequivalent/L. D. 9.0 to 12.0 milliequivalent/L. Correct, C. 4.8 to 8.4 milliequivalent/L. Rationale: therapeutic magnesium for seizure prophylaxis is higher than normal serum magnesium and typically between 4.8 to 8.4 milliequivalent/L. depending on lab/reference. Lower ranges are normal physiologic levels. Strategy: remember that therapeutic magnesium for eclampsia prophylaxis is supraphysiologic, choose the higher range. Question 6. A client is given betamethasone IM for fetal lung maturity at 28 weeks. What is the primary purpose of antenatal corticosteroids? A. Decrease maternal infection risk. B. Stimulate surfactant production in the fetal lungs. C. Delay preterm labor for 48 hours. D. Promote maternal glucose uptake. Correct. B. Stimulate surfactant production in the fetal lungs. Rationale: antenatal corticosteroids accelerate fetal lung maturity by enhancing surfactant production, reducing risk of respiratory distress syndrome. They do not directly delay labor, tocolytics do, and they can increase maternal blood glucose and have potential infection risks. Strategy: link corticosteroids to fetal lung maturity, surfactant. Question 7. Calculation. A laboring client is receiving oxytocin infusion at 6 ml/min via infusion pump. The concentration is 10 units in 1000 ml normal saline. How many ml/hr is the infusion running? 1 unit equals 1000 millunits, A. 6 ml per hour. B. 36 ml per hour. C. 60 ml per hour. D. 360 ml per hour. Correct. B. 36 ml per hour. Rationale: 10 units equals 10,000 mu in 1000 ml concentration equals 10 mu/ml. To deliver 6 mu/min need 0.6 ml per minute. 0.6 times 60 is equal to 36 ml per hour. Strategy: convert units carefully, units milliunits, then mu/ml, then ml/min ml/hr. Question 8. A breastfeeding mother is prescribed metoclopramide for nausea. She asks about effects on lactation. What should the nurse tell her? A. It may decrease milk production. B. It increases milk production by increasing prolactin. C. It passes into milk and causes neonatal sedation, avoid breastfeeding. D. It has no effect on lactation. Correct. B. It increases milk production by increasing prolactin. Rationale: metoclopramide can increase prolactin via dopamine antagonism and has been used off-label to augment lactation. It crosses into breast milk but is not routinely contraindicated. Monitor infant for rare sedation. Strategy: no drug mechanisms, dopamine antagonists raise prolactin. Question 9. A woman has polyhydramnios and preterm labor. The provider orders indomethacin to reduce fetal urine output. The nurse should monitor the fetus for which drug-related complication? A. Patent ductus arteriosus, PDA, closure. B. Maternal hypertension. C. Fetal hypoglycemia. D. Placental abruption. Correct. A. Patent ductus arteriosus, PDA, closure. Rationale: NSAIDs like indomethacin can cause premature closure of the fetal ductus arteriosus and oligohydramnios due to reduced fetal urine output. They are used cautiously and typically before 32 weeks only when benefits outweigh risks. Strategy: for fetal risks from maternal drugs, think about pharmacologic targets, prostaglandin inhibition, ductal constriction. Question 10. A client in active labor is given terbutaline subcutaneously for uterine tachysystole. Which maternal adverse effect is most associated with terbutaline? A. Bradycardia. B. Hypotension. C. Hyperglycemia and tachycardia. D. Oliguria. Correct. C. Hyperglycemia and tachycardia. Rationale: terbutaline is a beta-2 agonist. Side effects include maternal tachycardia, tremors, and hyperglycemia. It can also cause hypotension in some, but tachycardia and metabolic effects are classic. Strategy: associate beta agonists with sympathetic stimulation effects. Question 11. Select all that apply. Which medications are commonly used for postpartum hemorrhage management? A. Oxytocin. B. Carboprost, Hemabate. C. Nifedipine. D. Misoprostol, Cytotec. E. Terbutaline. Correct. A, B, D. Rationale: oxytocin, carboprost, a prostaglandin, and misoprostol are uterotonics used to manage postpartum hemorrhage. Nifedipine and terbutaline are uterine relaxants used for tocolysis, not hemorrhage. Strategy: categorize drugs into uterotonics versus tocolytics. Question 12. A client with group B strep in labor is started on 4-penicillin G. 2 hours after the infusion begins, she develops wheezing and hypotension. What is the nurse's best next action? A. Stop the infusion and initiate anaphylaxis protocol. B. Slow the infusion rate. C. Monitor vital signs every 5 minutes. D. Administer 4-diphenhydramine and continue infusion. Correct. A. Stop the infusion and initiate anaphylaxis protocol. Rationale: wheezing and hypotension during an antibiotic infusion indicate possible anaphylaxis. Immediate stopping of infusion and starting emergency treatment, epinephrine, airway support, is required. Slowing or continuing is contraindicated. Strategy: recognize signs of anaphylaxis and act immediately, stop the offending agent. Question 13. Which of the following tocolytics is contraindicated in the presence of maternal cardiac disease? A. Nifedipine. B. Indomethacin. C. Terbutaline. D. Magnesium sulfate. Correct. C. Terbutaline. Rationale: terbutaline is a beta agonist with cardiovascular stimulating effects, contraindicated in significant maternal cardiac disease. Nifedipine, calcium channel blocker, and magnesium have cardiovascular. Question 14. A neonate of a mother who received magnesium sulfate during labor is observed to be hypotonic and has respiratory depression. What is the best initial nursing action? A. Give 4-calcium gluconate to the neonate. B. Place the neonate under radiant warmer only. C. Suction the airway and provide stimulation. D. Administer naloxone. Correct. C. Suction the airway and provide stimulation. Rationale: immediate neonatal airway support and stimulation are first line for depressed neonate. If magnesium toxicity is suspected and respiratory depression persists despite supportive care, calcium gluconate may be used under neonatal provider direction. Naloxone treats opioid depression, not magnesium. Strategy: follow neonatal resuscitation priorities, airway, breathing, circulation before antidotes. Question 15. Select all that apply. A woman taking magnesium sulfate reports flushing and warmth. Which findings would indicate magnesium toxicity? A. Respiratory rate 10 per minute. B. Absent deep tendon reflexes. C. Urine output 30 milliliters per hour. D. Oxygen saturation 98% on room air. E. Heart rate 80 per minute. Correct. A, B, C. Rationale: respiratory depression, loss of DTRs, and oliguria, less than 30 milliliters per hour suggests accumulation because magnesium is renally excreted, are signs of magnesium toxicity. Good oxygenation and normal HR are not toxicity indicators. Strategy: on SATA, choose physiologic derangements consistent with toxicity and drug elimination. Question 16. A pregnant woman at 34 weeks is given erythromycin ointment to the neonate after delivery. What is the primary purpose of this medication? A. Prevent gonococcal ophthalmia neonatorum. B. Treat chlamydial conjunctivitis. C. Vaccinate the neonate against ophthalmic infections. D. Promote eyelid opening. Correct. A. Prevent gonococcal ophthalmia neonatorum. Rationale: erythromycin ophthalmic is given prophylactically to prevent Neisseria gonorrhoeae eye infections that can cause blindness. It may have some activity against chlamydia but is primarily for gonococcus. It is prophylactic, not a vaccine. Strategy: for prophylactic neonatal meds, recall standard newborn protocol, erythromycin for gonorrhea, vitamin K for clotting. Question 17. A woman with preterm labor is given nifedipine. Which maternal assessment finding indicates a common side effect? A. Bradycardia. B. Headache and dizziness. C. Urinary retention. D. Increased uterine tone. Correct. B. Headache and dizziness. Rationale: nifedipine, a calcium channel blocker, can cause vasodilation leading to headache, dizziness, and flushing. Bradycardia may occur with other agents. Urinary retention and increased uterine tone are not typical. Strategy: link antihypertensive/vasodilator mechanisms to vasodilation symptoms. Question 18. Priority. A client in active labor who was given a bolus of oxytocin suddenly reports severe chest pain and shortness of breath. Which is the nurse's priority action? A. Administer sublingual nitroglycerin. B. Stop oxytocin and call for emergency help. C. Place the client in Trendelenburg position. D. Give oxygen and assess fetal heart rate. Correct. B. Stop oxytocin and call for emergency help. Rationale: sudden chest pain and dyspnea could indicate pulmonary edema or myocardial ischemia possibly exacerbated by fluid shifts and oxytocin effects. Stop the infusion and summon emergency assistance. Oxygen and FHR assessment are important, but removing the inciting agent and escalating are priority. Strategy: for acute severe events after medication administration, stop the med and activate emergency response. Question 19. A client on magnesium sulfate reaches a serum magnesium level of 9.2 milliequivalent/L and shows absent reflexes. What is the antidote and recommended route? A. Protamine sulfate 4. B. Calcium gluconate 4. C. Naloxone 4. D. Vitamin K 4. Correct, B. Calcium gluconate 4. Rationale: calcium gluconate is the antidote for magnesium toxicity and should be administered 4 under provider orders. Protamine reverses heparin, naloxone reverses opioids, vitamin K reverses warfarin effects. Strategy: memorize key antidotes for emergency reversal of common OB drugs. Question 20. A client with asthma is in preterm labor. Which tocolytic is least appropriate for her? A. Magnesium sulfate. B. Terbutaline. C. Nifedipine. D. Indomethacin. Correct, B. Terbutaline. Rationale: terbutaline may actually be used in asthma for bronchodilation, however, it can precipitate serious cardiac tachyarrhythmias and is used cautiously. The question likely tests awareness that beta agonists may interact with maternal cardiac conditions. However, terbutaline can be beneficial to bronchospasm. This is a tricky item. Most clinicians avoid terbutaline for prolonged tocolysis due to maternal cardiovascular risks. Given complexity, terbutaline is least appropriate for tocolysis in patients where cardiac risk is a concern. Magnesium and nifedipine are commonly used alternatives. Indomethacin is used earlier gestationally. Strategy: on nuanced items, pick the drug associated with the greatest maternal systemic risk for prolonged use. Question 21. Question 21. A laboring client receives a continuous epidural analgesic infusion containing bupivacaine and fentanyl. Which maternal sign should prompt immediate assessment of respiratory status? A. Mild pruritus at the infusion site. B. Respiratory rate of 8 breaths/min. C. Slight hypotension with BP 160. D. Nausea. Correct, B. Respiratory rate of 8 breaths/min. Rationale: opioids and epidural infusions can cause respiratory depression. RR of 8 is dangerously low and requires immediate assessment and possible naloxone. Pruritus and nausea are opioid side effects but not immediately life-threatening. Mild hypotension is common with epidural local anesthetics. Strategy: prioritize respiratory compromise signs when opioids are used neuraxially. Question 22. Select all that apply. Which medications are appropriate for treatment of maternal hypertension in pregnancy? A. Labetalol. B. Methyldopa. C. ACE inhibitors, e.g., enalapril. D. Hydralazine. E. ARBs, e.g., losartan. Correct, A, B, D. Rationale: labetalol, methyldopa, and hydralazine are commonly used antihypertensives in pregnancy. ACE inhibitors and ARBs are contraindicated due to teratogenicity and adverse fetal renal effects. Strategy: no pregnancy-safe antihypertensives, avoid ACE inhibitors/ARBs. Question 23. A client is given magnesium sulfate, later she becomes drowsy and has a respiratory rate of 10 per minute. The provider orders calcium gluconate 1G4. What is the rationale for calcium administration? A. To increase renal excretion of magnesium. B. To directly antagonize the neuromuscular effects of magnesium. C. To reverse any hypotension from magnesium. D. To cause diuresis. Correct, B. To directly antagonize the neuromuscular effects of magnesium. Rationale: calcium gluconate antagonizes the neuromuscular blockade caused by magnesium by restoring calcium-mediated synaptic transmission, reversing toxicity. It does not directly increase magnesium excretion. Strategy: remember, calcium is the physiologic antagonist of magnesium at the neuromuscular junction. Question 24. A mother with active TB is breastfeeding and needs treatment. Which medication is safe and should be continued with breastfeeding while treating active TB under medical supervision? A. Isoniazid. B. Rifampin. C. Ethambutol. D. All of the above with appropriate monitoring. Correct, D. All of the above with appropriate monitoring. Rationale: the standard TB drugs, isoniazid, rifampin, ethambutol, are not absolute contraindications to breastfeeding. The mother should receive treatment and infant should be assessed and given prophylaxis if indicated. Decisions are individualized with infectious disease/public health guidance. Strategy: for infectious disease meds, consider risk/benefit and consult protocols. Breastfeeding is often still recommended with treatment. Question 25. A woman who received neuraxial opioids postpartum complains of severe pruritus. What is the most appropriate initial nursing intervention? A. Administer naloxone. B. Give an opioid antagonist and discontinue analgesia. C. Offer oral antihistamine, e.g., diphenhydramine, or low-dose nalbuphine as ordered. D. Reassure the patient that pruritus will resolve in weeks. Correct. C. Offer oral antihistamine, e.g., diphenhydramine, or low-dose nalbuphine as ordered. Rationale: neuraxial opioids commonly cause pruritus. Treat with antihistamines or opioid agonist-antagonists, e.g., nalbuphine, as ordered. Naloxone is reserved for severe respiratory depression since it reverses analgesia. Strategy: match symptom to lowest risk treatment that preserves analgesia when possible. Question 26. Calculation. A client receives magnesium sulfate 4G4 loading dose over 20 minutes followed by maintenance infusion 2G/HR. How many ml/HR will the maintenance infusion be if the solution concentration is 20 G in 1000 ml? A. 10 milliliters per hour. B. 100 milliliters per hour. C. 200 milliliters per hour. D. 50 milliliters per hour. Correct. D. 50 milliliters per hour. Rationale: concentration equals 20 G/1000 ml 20,000 milligrams per 1000 milliliters equals 20 milligrams per milliliter. Maintenance 2G/HR equals 2000 milligrams per hour. Required ml/HR equals 2000 milligrams divided by 20 milligrams per milliliter equals 100 milliliters per hour. Wait, check math. 20 G/1000 ml equals 20,000 milligrams per 1000 milliliters equals 20 milligrams per milliliter. 2000 milligrams per hour divided by 20 milligrams per milliliter equals 100 milliliters per hour. Correct answer is B. Correction applied. Correct. Revised B. 100 milliliters per hour. Strategy: always convert grams mg and compute mg/ml before dividing. Question 27. A pregnant woman with gestational diabetes is started on insulin therapy. Which statement is correct about insulin use in pregnancy? A. Oral hypoglycemics are preferred to insulin. B. Insulin requirements typically decrease in second and third trimesters. C. Insulin does not cross the placenta and is safe for fetus. D. Rapid-acting insulins are contraindicated in pregnancy. Correct. C. Insulin does not cross the placenta and is safe for fetus. Rationale: insulin is the standard treatment because it does not cross the placenta. Insulin requirements typically increase in the second and third trimester due to insulin resistance. Some oral agents, e.g., glyburide/metformin, are used selectively but insulin remains mainstay. Strategy: remember insulin's safety in pregnancy, does not cross placenta. Question 28. A patient is given carboprost, hemabate, for postpartum hemorrhage. Which condition would make carboprost contraindicated? A. Asthma. B. Hypertension. C. Diabetes mellitus. D. Iron deficiency anemia. Correct. A. Asthma. Rationale: carboprost, a prostaglandin F2 alpha analog, can cause bronchospasm and is contraindicated in asthma. It may raise BP and affect glucose, but asthma is a specific contraindication. Strategy: match drug adverse effect, bronchospasm, to patient condition. Question 29. Select all that apply. Which maternal medications can cause neonatal central nervous system depression if given shortly before delivery? A. Magnesium sulfate. B. Diazepam. C. Hydralazine. D. Opioids, e.g., morphine. E. Oxytocin. Correct. A, B, D. Rationale: magnesium, benzodiazepines, and systemic opioids cross placenta and can depress neonatal CNS and respiration. Hydralazine can cause maternal hypotension but is not a major neonatal depressant. Oxytocin does not depress neonate. Strategy: for neonatal depression risk, choose drugs with known CNS depressant effects. Question 30. A postpartum client with uterine atony has received oxytocin with minimal response. The provider orders methylorgonavine IM. What nursing assessment must be completed prior to administration? A. Check maternal blood pressure. B. Assess hemoglobin level. C. Confirm pain scale. D. Verify fetal heart rate. Correct. A. Check maternal blood pressure. Rationale: methylorgonavine is contraindicated in hypertension. BP must be assessed and within acceptable range before administration. Strategy: always screen for contraindications tied to a drug's physiologic effects. Question 31. Question 31. A client on magnesium sulfate develops hypotension and flushing after a rapid bolus. Which underlying mechanism explains these effects? A. Histamine release from mast cells. B. Peripheral vasodilation due to magnesium. C. Beta-adrenergic blockade. D. Increased myocardial contractility. Correct, B. Peripheral vasodilation due to magnesium. Rationale: magnesium causes peripheral vasodilation leading to flushing and hypotension, especially with rapid boluses. Strategy: associate physiologic manifestations, flushing, hypotension, with vasodilatory drug effects. Question 32. Which medication is commonly used for cervical ripening and induction of labor and can cause uterine hyperstimulation if misused? A. Dinoprostone, prostaglandin E2. B. Methergine. C. Magnesium sulfate. D. Betamethasone. Correct, A. Dinoprostone, prostaglandin E2. Rationale: dinoprostone and other prostaglandins are used for cervical ripening/induction and can cause uterine hyperstimulation leading to fetal distress. Strategy: think, prostaglandins ripening/induction hyperstimulation risk. Question 33. Select all that apply. Which intervention should the nurse implement for a patient receiving oxytocin infusion? A. Continuous fetal heart rate and contraction monitoring. B. Assess uterine resting tone frequently. C. Encourage ambulation during infusion. D. Titrate infusion per protocol and provider orders. E. Monitor maternal vital signs frequently. Correct, A, B, D, E. Rationale: oxytocin mandates continuous FHR/UC monitoring, assessment of uterine resting tone to avoid tachysystole, titration per protocol, and frequent maternal vitals. Ambulation is not appropriate during continuous oxytocin infusion. Strategy: for high-risk infusions, choose continuous monitoring interventions. Question 34. A client with preterm prom at 30 weeks receives a course of betamethasone and then is started on penicillin for GBS. She asks why she needs both. What is the best explanation? A. Betamethasone prevents infection and penicillin matures lungs. B. Betamethasone promotes fetal lung maturity, penicillin treats/prevents maternal fetal infection. C. Both medications are tocolytics. D. Both are to prevent premature labor. Correct, B. Betamethasone promotes fetal lung maturity, penicillin treats/prevents maternal fetal infection. Rationale: these drugs serve different but complementary purposes, steroids for lung maturation, antibiotics for infection prophylaxis/treatment. Strategy: explain distinct mechanisms and goals when multiple meds are used. Question 35. A patient is given a blood transfusion postpartum and developed an allergic reaction, urticaria, to donor blood. Which medication is appropriate to treat this reaction while allowing transfusion to continue? A. Epinephrine IM. B. Diphenhydramine 4. C. Hydrocortisone 4 and immediately stop transfusion. D. Naloxone 4. Correct, B. Diphenhydramine 4. Rationale: for minor allergic transfusion reactions marked by urticaria, diphenhydramine may be administered and transfusion may continue under close monitoring. Epinephrine is reserved for anaphylaxis, severe reactions require stopping the transfusion. Strategy: differentiate minor allergic reactions from anaphylaxis and select appropriate milder therapy. Question 36. Priority. A client in labor receiving oxytocin develops uterine tachysystole, greater than or equal to 5 contractions in 10 minutes. What is the immediate priority nursing action? A. Increase oxytocin infusion rate. B. Stop oxytocin infusion and reposition the client. C. Prepare for immediate cesarean delivery. D. Give prostaglandin agonist. Correct, B. Stop oxytocin infusion and reposition the client. Rationale: uterine tachysystole can lead to fetal compromise, stop the oxytocin to reduce uterine activity and reposition for improved uteroplacental perfusion. Cesarean may be needed if compromise persists. Strategy: address cause, oxytocin, quickly, then implement supportive measures. Question 37. A woman with eclampsia is seizing and has been given magnesium sulfate bolus. Which sign indicates the magnesium dose is effective? A. Cessation of seizure activity. B. Development of chest pain. C. Increase in blood pressure. D. Onset of dyspnea. Correct, A. Cessation of seizure activity. Rationale: magnesium sulfate is given to prevent and treat eclamptic seizures, effectiveness is shown by seizure control. Other signs indicate adverse effects. Strategy: always identify desired therapeutic outcome to judge effectiveness. Question 38. A client receiving prostaglandin E1, misoprostol, vaginally for induction has a temperature of 38.6 degrees Celsius and tachycardia. Which is the most appropriate interpretation? A. Normal side effect, no action needed. B. Possible uterine hyperstimulation with infection or drug-related fever, assess for uterine tenderness and fetal status. C. Always stop induction and start broad-spectrum antibiotics. D. Give antipyretic and continue as planned. Correct. B. Possible uterine hyperstimulation with infection or drug-related fever, assess for uterine tenderness and fetal status. Rationale: misoprostol can cause fever, tachycardia could signal maternal infection or hyperstimulation. Assessment and evaluation of fetal well-being and uterine status guide next steps. Strategy: don't dismiss fever, assess context and fetal status before deciding. Question 39. Select all that apply. Which interventions reduce the risk of neonatal hemorrhagic disease? A. Administer vitamin K to the neonate IM at birth. B. Administer erythromycin ointment. C. Ensure mother received antenatal vitamin K. D. Delay bathing the infant. Correct. A. Rationale: vitamin K given IM at birth prevents neonatal vitamin K deficiency bleeding. Erythromycin prevents ophthalmia. Maternal antenatal vitamin K is not standard for preventing neonatal hemorrhage. Delaying bathing does not affect hemorrhagic disease risk. Strategy: keep neonatal prophylaxis measures distinct and match them to their correct purposes. Question 40. A client taking valproic acid for bipolar disorder is newly pregnant. What is the primary fetal risk of continued valproate therapy? A. Neural tube defects, e.g., spina bifida. B. Cardiac malformations only. C. No increased risk, safe in pregnancy. D. Growth restriction only. Correct. A. Neural tube defects, e.g., spina bifida. Rationale: valproic acid increases risk of neural tube defects and neurodevelopmental issues. Discuss risks versus benefits and seek specialist input for medication changes in pregnancy. Strategy: identify high-risk teratogens and counsel early with multidisciplinary input. Question 41. Question 41. During tocolysis with indomethacin, the nurse monitors the fetus for which immediate adverse effect? A. Neonatal hypoglycemia. B. Premature closure of the ductus arteriosus. C. Polyhydramnios. D. Placental abruption. Correct. B. Premature closure of the ductus arteriosus. Rationale: indomethacin inhibits prostaglandin synthesis, risking ductal constriction and oligohydramnios due to decreased fetal urine. Strategy: for NSAID tocolytics, prioritize ductus-related fetal risks. Question 42. Select all that apply. Which signs suggest uterine inversion or severe hemorrhage requiring uterotonic agents and immediate intervention? A. Sudden severe pelvic pain and hemorrhage. B. A soft, boggy uterus above the umbilicus. C. Hypotension and tachycardia. D. Firm, well-contracted uterus with minimal bleeding. Correct. A. C. Rationale: uterine inversion presents with sudden pain and hemorrhage. Hypotension and tachycardia indicate significant blood loss. A boggy uterus suggests atony, postpartum hemorrhage, rather than inversion, and a firm uterus with minimal bleeding is normal. Strategy: rapid recognition of hemorrhage signs triggers uterotonics and emergency measures. Question 43. A client with severe preeclampsia is given hydralazine for blood pressure control. After dosing, she becomes tachycardic and complains of palpitations. What is the likely mechanism? A. Reflex tachycardia due to systemic vasodilation. B. Direct myocardial stimulation by hydralazine. C. Beta-adrenergic blockade. D. Enhanced vagal tone. Correct. A. Reflex tachycardia due to systemic vasodilation. Rationale: hydralazine causes arteriolar dilation, leading to reflex sympathetic activation and tachycardia. This is a common hemodynamic response. Strategy: for vasodilators, expect reflex sympathetic responses and counsel/monitor accordingly. Question 44. Priority. A client on magnesium sulfate becomes difficult to arouse and has absent DTRs and respirations of 6 per minute. Which action has the highest priority? A. Administer 4-calcium gluconate and support airway/ventilation. B. Call the provider and document findings. C. Decrease the magnesium infusion rate by half. D. Give 4-furosemide to increase excretion. Correct. A. Administer 4-calcium gluconate and support airway/ventilation. Rationale: this is magnesium toxicity with respiratory arrest risk. give calcium gluconate, antidote, and provide airway/ventilatory support immediately. Documentation and provider notification follow emergent care. Diuretics are not first line and are inappropriate if airway compromise exists. Strategy: prioritize life-saving reversal and respiratory support. Question 45. A woman with Group B strep receives penicillin in labor. Which neonatal outcome is most directly reduced by adequate maternal intrapartum antibiotics? A. Early onset neonatal sepsis. B. Late onset neonatal sepsis. C. Neonatal hypoglycemia. D. Neonatal hypothermia. Correct. A. Early onset neonatal sepsis. Rationale: intrapartum antibiotics markedly reduce early onset GBS sepsis in neonates, first week of life. Late onset disease is less impacted by intrapartum prophylaxis. Strategy: link timing of prophylaxis to timing of neonatal disease it prevents. Question 46. Select all that apply. Which medications are used to enhance uterine contraction after delivery to reduce hemorrhage? A. Oxytocin 4. B. Misoprostol rectally or orally. C. Ergonavine in hypertensive emergency. D. Carboprost intramuscularly. E. Terbutaline subcutaneously. Correct. A, B, D. Rationale: oxytocin, misoprostol, and carboprost are uterotonics used postpartum. Ergonavine, methylergonavine, is used but contraindicated in hypertension, not in hypertensive emergency. Terbutaline is a tocolytic and would worsen hemorrhage. Strategy: distinguish uterotonics versus tocolytics and know contraindications for each. Question 47. A mother receiving anticoagulant therapy with enoxaparin during pregnancy asks about epidural anesthesia at delivery. What is the safest nursing response? A. We can place an epidural anytime, no concerns. B. Anticoagulation increases risk of spinal hematoma, timing of dose relative to neuraxial procedure must be managed per protocol. C. You must stop enoxaparin immediately and cannot receive an epidural. D. Enoxaparin is safe, proceed with standard epidural. Correct. B. Anticoagulation increases risk of spinal hematoma, timing of dose relative to neuraxial procedure must be managed per protocol. Rationale: low molecular weight heparins increase risk of epidural/spinal hematoma. Epidural placement/removal timing must follow established guidelines regarding last dose and coagulation status. Strategy: for procedures, always consider anticoagulation timing and institutional policies. Question 48. Calculation. A patient receives magnesium sulfate infusion at 40 mg per kilogram per hour. She weighs 70 kilograms. What is the infusion rate in mg/hr and g/hr? A. 2,800 mg per hour, 2.8 g/hr. B. 280 mg per hour, 0.28 g/hr. C. 4,200 mg per hour, 4.2 g/hr. D. 40 mg per hour, 0.04 g/hr. Correct. A. 2,800 mg per hour, 2.8 g/hr. Rationale: 40 mg per kilogram per hour times 70 kilograms equals 2,800 mg per hour equals 2.8 g/hr. Strategy: multiply weight by mg/kg dose, convert mg left-right arrow g as needed. Question 49. A client in preterm labor receives nifedipine. She reports palpitations and flushing. The nurse's best response is: A. Stop the medication and call the provider immediately. B. Reassure that these are common side effects and monitor vital signs. C. Give epinephrine IM. D. Administer a beta blocker to counteract palpitations. Correct. B. Reassure that these are common side effects and monitor vital signs. Rationale: nifedipine commonly causes flushing and palpitations due to vasodilation, monitoring is sufficient unless symptoms are severe or hypotension occurs. Immediate cessation and emergency drugs are not indicated for mild side effects. Strategy: differentiate common tolerable side effects from signs of serious adverse events. Question 50. Question 50. A client with severe postpartum hemorrhage is receiving massive transfusion and is being given tranexamic acid, TXA. What is the intended therapeutic effect of TXA? A. Promote platelet aggregation by increasing thromboxane. B. Inhibit fibrinolysis by blocking plasminogen activation. C. Increase red blood cell production. D. Directly constrict uterine blood vessels. Correct. B. Inhibit fibrinolysis by blocking plasminogen activation. Rationale: Tranexamic acid is an antifibrinolytic that stabilizes clots by inhibiting plasminogen activation to plasmin, reducing bleeding. It does not increase RBC production nor directly constrict uterine vessels. Strategy: link TXA to antifibrinolytic action, used in hemorrhage to stabilize clots. And that's it for today's crash course on OB/maternity drugs you must know for the NCLEX. If you learned something new, don't forget to like, subscribe, and share this video with your study partners. It really helps the channel grow. Remember, the NCLEX isn't about memorizing, it's about understanding and applying. Keep practicing, stay focused, and I'll see you in the next video, right here on Nclex Made Easy 91, where we make nursing concepts crystal clear. Good luck, future nurses, you've got this.